Good morning. I'm Dr. Russ Leftwich. For the next 20 minutes, I am going to answer the question of why invest in FHIR interoperability. And I'm going to do that by telling the story of why we needed FHIR and how FHIR enables interoperability in healthcare. I'm going to start by going back to 2001 when fewer than 1 in 10 hospitals had electronic health records, and those that did couldn't share data because that data was not interoperable. In 2001, there was a conference at the US Institute of Medicine that produced a report called Crossing the Quality Chasm. That report addressed the fact that around the US, patients with the same condition in different hospitals did not have the same outcomes. Even patients with different physicians in the same healthcare organization didn't have the same outcomes. But it was not possible to answer the question of why, because we didn't have the data and we didn't have interoperability. So that report called for 6 aims for the 21st century of healthcare in the US. First, safer care to avoid harm to patients that occurred because the right data wasn't in the right place at the right time for the clinicians. More effective care based on using evidence-based medicine and avoiding wasteful treatments. Efficient and timely care by enabling sharing of data between care team members for individual patients across different organizations, and recognizing the differences in individual patients. And mind you, this was before DNA sequencing and genomics, and now we have an even greater need to recognize those individual differences. And effective care, recognizing that patients are limited by their social and economic conditions and need to all receive the same care. The care was to be patient-centered, recognizing differences. And another observation of that conference was that it took 17 years for new knowledge in research to reach the patient's care setting because of the time it took to publish new knowledge, have it disseminated, and actually applied to care. The aim was to make that a real-time process where new knowledge in research could reach the patient in near real time. So a decade later, there had not been much progress in EHR adoption, digital technology adoption, or interoperability. And the Standards Development Organization, Health Level 7 or HL7, asked a task force, what if we created a new standard from scratch for healthcare data? What would it look like? And that task force came forward with the concept that we now call Fast Healthcare Interoperability Resources, or FHIR. FHIR is, in its essence, a representational state API, a REST API. REST APIs are the basis of everything we do on the internet every day. It's the technology of the World Wide Web. And to explain it, I would describe a travel website where you go and you enter that you want to travel from Jakarta to Singapore on September 30th, and you see flights from different airlines with different prices. That's not because the airlines have downloaded the schedules, the website has downloaded the schedule of all the airlines, it's because the airlines have agreed on how to represent the data in an airline flight, how to ask for it, and what you're going to get in return. That is uh, the same technology of that FHIR represents, and it's the meaning of the data in healthcare. That's where it gets more complicated, and that meaning is defined in the FHIR specification. There are two important things to understand about FHIR. The first is FHIR resources. That's resources as in URL. You remember that stands for Uniform Resource Locator. FHIR resources are discrete data concepts that describe things in healthcare, like a patient, a medication, a condition or diagnosis, an observation like a lab test. Each of those resources is computable, and inside the resource are all the data elements that are necessary to describe that thing in healthcare. They are the rules for the data in that resource. They are more than just the name of, say, a condition, because for the condition resource, it also indicates who this condition or diagnosis applies to, who made that diagnosis, when it was made, where it was made, when the condition began, whether it's active or not. All of that is inside the resource as data elements that are computable and can be understood by computer systems. The second thing to understand about FHIR is FHIR profiles. FHIR profiles are not part of the FHIR standard. FHIR profiles are what we create from the FHIR standard. They are customized resources for each use case. So for a particular use case, you customize a profile, a resource to make a profile for that particular use case. It has the rules for the data in that use case, the vocabulary bindings, code system bindings that apply to that use case. And if you need a data element that is not part of the FHIR standard, you add that with a FHIR extension. That is a FHIR profile. Like the FHIR resources, they are computable, can be understood by computers, and interoperability does not come from just using the FHIR standard. Interoperability comes from different systems using the same FHIR profile for the same use case. What that means is that we can use that data in a particular FHIR profile in different interoperability paradigms. We can get the data from a FHIR API, a REST API. We can put it in a message. We can put it in a document. And we can use it in decision support services, because everything in FHIR is inherently computable as it is. It also means that we can ask a system, query a system for exactly the data we want. We don't have to get an entire document about a patient and then look for the data that we want. We can get just the data that we need, whether it's the medications from a year ago, a lab test over the past 3 years. We get just the information that we want and need. Now, it's said that true interoperability is when we exchange data and we mean the same thing. But it's not we as humans who need to mean the same thing. It's our computer systems that need to mean the same thing. And that's more complicated. Let me give you an analogy. So if two individuals had never seen this animal before, and one of them says it's a white horse with black stripes, and the other one says it's a black horse with white stripes, they would figure it out very quickly that they're talking about the same thing. But to a computer system, those are two absolutely different things. True, we could program it to understand they're the same, but in healthcare, there are literally tens of thousands of data concepts that can be described in two or more ways, and we can't program all of that into our computers. So we create what are called clinical information models. They're the rules for the data in a particular data concept, the terminology and vocabulary bindings, and the uh, the use case restrictions for that particular data. That is implemented as a FHIR profile. That is how we create interoperability for each use case using FHIR. So have we had data models before? Well, we used clinical documents as the data model. And if there's a piece of data, we understand from where it is in the document, its relationship to the other data in that document for that patient. So we need to recreate with FHIR profiles those relationships between different data elements for that individual patient and between different FHIR resources for that patient. But we do that using the computability of the FHIR standard. So when we gather together the FHIR profiles that we need for a particular use case, we combine them into a FHIR implementation guide. An implementation guide then becomes the rules for interoperability for that particular use case. So for example, if it's an implementation guide for procedures, and they might be lab procedures or imaging procedures, they all need the same FHIR resources. There's a procedure resource, patient resource, practitioner, encounter, and condition resource that would be needed for that FHIR implementation guide for a procedure. And that's how we create shareable interoperability with FHIR. Now, one of the important components of the FHIR standard is FHIR terminology services. That means that we can store code sets and value sets from those code sets for particular use cases on a FHIR server, and they become available to all of the applications and all of the organizations that are using and implementing interoperability for that particular use case. They access the same FHIR terminology server to get those value sets and code systems and create interoperability. So those FHIR implementation guides, like everything else, are computable or understandable by a computer system and can be downloaded from a URL published by the HL7 organization and used in different organizations to create interoperability. So the whole FHIR standard continues to evolve. And like everything else in the current age that we've become accustomed to, technology that continues to evolve and improve, FHIR is the same way. We are continuing to develop FHIR, and each new release of FHIR has new capabilities and new content. Now, most countries in the world are using FHIR Release 4. There will, in a couple of years, be a new release of FHIR to be adopted and to add new capabilities. Now, there are four things that you should take away from today's discussion. One is that FHIR is machine readable, and everything we create from it is machine readable. Another is that interoperability is dependent not just on using FHIR, but on using the same FHIR profile for a particular use case. Another is that we can share FHIR data to improve the healthcare of individuals with that interoperability. I want to say a bit about what's being done with FHIR. There are literally hundreds of use cases and thousands of FHIR applications in use every day, but it's not possible to summarize it because each of those individual applications is interoperable based on its own FHIR implementation guide. There are applications being used for care delivery, for care coordination, for decision support, and for patients to access their data in EHR systems. And there are FHIR applications for public health reporting. I do want to mention a couple of applications that have been developed at a national level in the US, both because of the COVID pandemic and the data requirements that it has created. The first is a case reporting app called eCase Report Now, ECR Now, that is a way to create case reports for COVID patients or patients with other conditions and submit them to public health. It was developed because the paper-based system of case reports was not scalable at all to the level needed for the COVID pandemic. So the Association of Public Health Laboratories in the US developed this application that can go to EHRs or health information exchanges, get data about individual patients who have COVID, and then submit that data to a public health agency in that locality or in that region so that the activity of COVID could be tracked. A second application that has been developed is one developed by the US Food and Drug Administration that has the responsibility for tracking data about adverse reaction reports to drugs, biologicals, and vaccines in the US. So the FDA must receive those reports and then investigate them. That too was a paper-based system in the past. With the onset of the COVID vaccines, the availability of COVID vaccines, the number of adverse reaction reports for vaccines went from 50,000 a year to 1 million a year. And the FDA had to develop a way to consume these, to investigate these reports. And they did this by implementing InterSystems IRIS FHIR repository because of its scalability and the need to have a FHIR repository at a national level. They could then query the EHR systems using InterSystems IRIS to get the FHIR data from those EHR systems for the patients that were having reactions, put it in a FHIR repository, and do analytics on that data. So with that, I'm going to conclude this story about why we needed FHIR, and I'm going to turn the stage over to Ms. Stella Ramette, who, after I have told you why we need FHIR, will tell you why we need InterSystems FHIR. Thank you.